Perspective of these simple formulas or diagrams, however you want to call it. So short-term regulation. Short-term regulation is sympathetic, parasympathetic, right? Sympathetic increases heart rate and contractility. So if I have increased heart rate, I will increase cardiac output and blood pressure. If I increase contractility, I increase stroke volume, cardiac output, blood pressure. Everybody with me? If I increase, if I have vasoconstriction, which sympathetic nervous system also does, I decrease radius, which increases resistance and increases blood pressure. So this makes much more logical sense than if you just have to memorize different parts. It just kind of flows better, okay? So that's increasing blood pressure with a sympathetic help. Parasympathetic works the same way in opposite direction, obviously. There's only one exception to the rule. It does not innervate vessels. So it's not the parasympathetic stimulus that causes vasoconstriction, it's a lack of sympathetic. Which of course, when we turn on parasympathetic, we turn on parasympathetic, right? Excuse me, the other way around. Well, yeah, both ways. Yeah, everybody comfortable with that? Mm-hmm. When we talk about the long-term regulation, it is activating or deactivating kidneys, right? So if I need to increase blood pressure, I would, what do I want the kidneys to do if I want to increase the blood pressure?
Produce less antidiuretic.
I want to produce less P. Because where does it fit in my formula? If I make less P, I have bigger volume of blood. And if I have bigger volume of blood, my preload increases. And if preload increases, stroke volume increases. And then cardiac output, and then the blood pressure. Agreed? Okay, so how I do it is through the renin-angiotensin system. I'd like to go through this one more time because it is complex. This is definitely complex, okay? So spend time practicing that, and I promise you I will ask you questions about that. Okay, so if the blood pressure is too low, kidney senses it. It has its own baroreceptors, right? Produces renin. Renin clips inert angiotensinogen, turning it into angiotensin 1. Angiotensin 1 circulates through in the blood, and when it goes through the lungs produce yet another enzyme called angiotensin converting enzyme, or ACE enzyme, okay? And that converts angiotensin tensin 1 into angiotensin 2. Angiotensin 2 does three things. Number one, it induces the production of aldosterone. Aldosterone acts on the kidneys, right? Second, it acts on posterior pituitary to produce antidiuretic hormone, which also acts on the kidneys. Together, they cause the kidney to reabsorb water. When we reabsorb water, we retain water. We keep more water with us. That increases the preload, well, eventually, yeah, preload, which causes increased stroke volume, cardiac output, and blood pressure. You see that? Mm-hmm. Okay. Second thing that both ADH and angiotensin do is vasoconstriction. Vasoconstriction. And it is in the name, angiotensin, pressure in the vessel. Do you know what's the other name for ADH? Vasopressin. Which is like using different roots to say the same thing as angiotensin, isn't it? So they both cause a vasoconstriction. How's vasoconstriction help? This goes down, this goes up. Everybody with me? Mm-hmm. And by a margin. And so we increase the blood pressure. Yeah.
Both of those are happening at the same time?
Up.
The vasoconstriction and the
yep.
antidiuretic.
Correct, and the water retention, yes. Okay. So, actually let me go back for 1 second. Why do I want you to keep that all in mind? Now you have a patient who's got high blood pressure. There are several things that we can do. And usually we have drugs in multiple categories that affect different parts of this regulatory mechanism or mechanisms that help us lower the blood pressure. Each one category usually lowers it about 5 millimeters of mercury. So if your normal blood pressure is 120 and you have 150, it will take numerous drugs. So let me show you. I'm not going to test you on drugs, but I want you to think ahead further. For example, one category of drugs is called ACE inhibitor. What will happen if I'll block ACE enzyme? I'll never make angiotensin II. And angiotensin II, through all these mechanisms, causes high blood pressure. Does it make sense? Second thing, or actually the first thing we would start patients on would be diuretics. What is a diuretic? Yeah, it's a P hormone. It's a P hormone. Why does it work? Well, if we pee more, we have less blood volume. We have less blood volume, we have less preload, less stroke volume, less cardiac output, less blood pressure. Does it make sense? Another drug that would be not a renin-angiotensin system would be beta blocker. What is beta blocker? What is beta? Where did I hear the word beta? Receptors for sympathetic nervous system. And we're specifically in the heart. In the heart. So if I block sympathetic nervous system from overexciting the heart, then heart rate and contractility would not go up, which of course will decrease cardiac output and decrease blood pressure. I can also give my patients alpha-1 blocker. You see how many drugs in this category? Yes, alpha-1 blocker, what would that do? Alpha-1, where did I hear that word? Oh, alpha-1, alpha-1. Also sympathetic receptors, where are they found? Peripheral vessels. So if sympathetic nervous system is not allowed to stimulate peripheral vessels, what would happen?
There's no dilation of the vessels.
There is no constriction of the vessels. And the vessels are not constricting, then resistance is not going up and the blood pressure is not going up. Do you see how all of these, and there are also angiotensin receptor blockers and so on and so on. So I don't want to get you into all of the different categories. We can even use calcium channel blockers to decrease contractility of the heart or vasospasm in the vessels. But I don't want to give you a course of pharmacology. But I want you to be thinking about different aspects that are involved in normal regulation. And so when things are out of control, how we can lower that pressure. Hypertension is huge. Heart disease is huge. Diabetes is huge. These are the 3 types of pathologies that no matter where in medicine you will go, you will see a ton of these patients on daily basis. So understanding that is very important.
So why, if they give them ACE inhibitors, why would they put them on an IV then?
On what?
An IV. Why would they have an IV in them? If
Like a drip?
Yeah.
Well, usually we put IV as a quick access to regulate things that could be shifting very quick. We don't necessarily put a large volume of fluid
Not for
in.
hydration.
And why do we put any fluid in? Is because we want to have that line open.
Okay.
That's all. Yeah, we don't necessarily transfuse, quarts and quarts of fluid. We just something that I can add to a little bit of drip so that I can fine tune. IV drugs act faster and the dosage is much more precise than if you're doing like per os or because somebody absorbs more or less, somebody absorbs faster or slower, and so on and so on. Whatever I put in the vein, it's gonna go directly to the receptors and act. Does that make sense?
Okay.
So usually it's like for a more precise control. Everybody or quicker control. Okay. Did we get the blood pressure regulation? Did I convince you it's an important topic? Okay, good deal. Alrighty. So I'm gonna discard that and I'm gonna move to our discussion of microcirculation. There are clinical applications that you might want to benefit from. So microcirculation. So what am I talking about? I'm talking about capillaries, right? Maybe arterioles and that kind of stuff. So capillaries, what's the big difference between capillaries and all other vessels? We don't have 3 layers in the wall. And why not?
Because
I want thin barrier for better exchange. It's like making coffee through a cardboard filter. You'll never get any coffee out of it, right? So if you want coffee, make it thin. Same thing here. If you want exchange, make it thin, okay? So all we have is a simple squamous epithelium on the thin basement membrane, which is very permeable. It's not a barrier, really. And then periocytes, this just holds these cells together. It's not really covering the whole surface, okay? All right, capillaries come in 3 flavors based on their permeability. And the 3 flavors are?
tenuous.
Yes, strawberry, chocolate, and vanilla. No. Continuous, fenestrated, and sinusoidal. Absolute majority of capillaries are continuous. In other words, there are no holes between the cells or within the cells. So if I need to exchange something, I have to go through the wall or through the simple squamous epithelium. Does that make sense? All right, so absolute majority. Fenestrated. Actually, let me show you. So this is a continuous capillary. You can see that the endothelium covers the entire lumen, and here's my basement membrane, and periodically I see periocyte. Now look at the fenestrated capillary. It looks like these cells have been shot with a BB gun, microscopic BB gun, right? Fenestra in Latin means window, okay? So it has those tiny openings. So why? We have these capillaries strategically placed where we want larger molecules to be able to cross the barrier. Where do we have it? Well, for example, in small intestines where I'm absorbing relatively large molecules. Or in the kidneys where I want to get rid of waste products and these molecules could be larger. Endocrine glands, why do you think in endocrine glands? What's happening in endocrine glands? They produce, what do endocrine glands produce, people? Hormones.
Yeah.
Well, these hormones, in order to have a title, this is a hormone, what has to happen? Has to travel by blood. So I gotta get in the blood. So if that is a bigger molecule, in order to hop the bloodstream, to hop the train, I gotta be able to get on it, right? So fenestrated capillaries are more common there as well, right? Finally, sinusoidal capillaries. Look at the holes. Now, it's not a BB gun shot, it's cannonball shot, right? Ginormous openings. So these capillaries would be the leakiest of them all. Would you agree with me? Continuous are the least leaky. Sinusoidal are the most leaky capillaries. Again, thinking about where do I need it? Where cells exit or enter the bloodstream. Where do they enter the bloodstream? Bone marrow, that's where I make blood cells, correct? So in order to put them on that train, they gotta be able to get into a capillary, yeah? All right, so that's sinusoidal. Where do they exit the train when they're old and broken and need to be disassembled? That's liver and spleen. Make sense? Okay, so very, very logical. And lymphatic tissue as well, like lymph nodes. Those are also very leaky capillaries because we want white blood cells. White blood cells really a special case because they can squeeze through very tiny holes, unlike other type of cells. but it facilitates their exit. Okay, all right. So also, instead of giving you the slide, let me just go to the picture. So what I want to point out here is, this is my arteriole. Arteriole is the smallest size artery, right? Then I have the capillaries and I have a venule. Now, on the entry into each capillary, I have just a few smooth muscle cells wrap around. And they're called pericapillary sphincters. What's the purpose of the pericapillary sphincters? When they constrict the flow through that capillary, you know, the picture on the bottom shows like empty capillaries. That actually never happens. But it can diminish it dramatically. Why do I need that? Do you remember how we talked about we don't have enough blood to fill all of the vascular beds to their maximum capacity? So we always prioritizing. You're working, you're getting the flow. You're not working, you're not getting the flow. Now you're working, you're getting the flow. You're resting, you're not getting the flow. Make sense? So this is how it's done. It's right here. Arterioles constrict by also pericapillary sphincters constrict. So when they constrict, the blood doesn't fill these capillaries, or very little, and goes through this vessel. And this is called metarteriole. Metarteriole just directly takes it to the venule, bypassing capillaries. And that allows us to prioritize the flow to some other organ. Does that make sense? When do we do this prioritization? When do you think we do that?
When something's healing.
Always. Always. We always do this. There's never a state where our vessels are not doing that. Sometimes these vessels are constricted, these are relaxed. Sometimes these are constricted, these are relaxed. Let me give you an example. Have you heard that you should not exercise, especially like go swimming, or go sit in a hot tub after a meal? Why not?
Because your digestive system is working and it's.
So what? Why can't I digest and sit in a hot tub? It feels very comfortable.
Well, it takes away from your digestive system.
No.
Well, the blood that's going.
Blood!
Yes.
Yes. When I just ate, what happens, which of the pictures shows the capillary beds after a meal?
The top.
In the gut.
The top.
Top. If I'm sitting in the hot tub, or if I'm exercising, my muscles, or if I'm exercising, or my skin vessels will also do this. And then there's not going to be enough to send it up here. Does that make sense? So you can't make too many vascular beds to do this, right? If you're exercising, your gut should be doing this, your muscles should be doing this. Does that make sense? If you're digesting after a meal, this should be your gut and this should be your muscles. Does that make sense? Oh, okay. All right. Okay, so that's just kind of how microcirculation works. Now let's talk about how do we actually exchange through the capillary wall. Not just flow through that vessel, but how do we exchange nutrients, gases, all of that stuff. All right, so what we're gonna do is we're gonna look at the capillary. This is gonna be the side of arteriole. This is gonna be the side of the vein, right? So the blood flow occurs in this direction. Everybody with me? Okay, so arterial and venular end. We will need to consider several pressures, but why are we talking about it? When we are talking about exchange, we always have to think about two factors, means and opportunity. It's like in the criminology show, criminalistic shows, or a thriller book, right? Could this be a murderer? Well, did they have an opportunity? Were they even there, right? Number two, did they have a motive, right? Did they have a reason to kill this person? Okay. So when you're talking about exchange, it doesn't matter what exchange you're talking about. If you're talking about filtration in the kidneys, filtration in the capillaries of my biceps brachii, or if you're talking about, it doesn't matter, exchange of gases in the lungs. You gotta meet two criteria, absorption of nutrients, any of this, two criteria. Do we have the means? We said yes, capillaries have the means because they have very thin barrier, correct? All right, number two, is there an opportunity? Is there a desire? Is there a desire to cross? Why do things flow? There's always one answer, because there is a pressure gradient. There is always a pressure gradient for any fluid, which is gas or liquid. If there's pressure gradient, there's gonna be a flow. If there is no pressure gradient, you're out of luck. Make sense? So let's see if there is a pressure gradient. Well, we have different pressures contributing to this overall pressure gradient. So there is a hydrostatic pressure and there is an osmotic pressure. So let's first of all start with hydrostatic pressure. Actually, let's backtrack. What is pressure? How do you, in your mind, in your mind's eye, you have this movie playing. I am imagining pressure. What am I thinking?
The load that well, in this regard, it's the amount of force on
the
partic-
wall
on
of the
walls
capillary,
cap-
correct.
yeah.
So the way I imagine it is my molecules are running and they're bumping in the wall and they apply pressure. Okay, blood in the capillary is under pressure because heart pushes it, right? And these molecules are pushed from molecules from the back, and those are pushed from molecules behind them, and so on, right? And they're running forward, but some of them accidentally hit the wall. Do you visualize that? Okay, that is hydrostatic capillary pressure. Okay, that is hydrostatic. Hydrostatic means hydrofluid, right, the water, static, so that's the pressure. Okay, now, it is different on the arterial end of the capillary versus venular end. Why do you think that is? The closer I am to the pump, the more pressure I experience from the guys behind me. Does that make sense?
Mm-hmm.
So which end is closer to the heart? Well, arterial end. On the arterial end, it is maybe 35 millimeters of mercury. Do not memorize numbers. This is just to demonstrate how that works. Maybe 15 on the venular end. Significant drop, yeah? Okay, fantastic. Now, do you think there are molecules of fluid outside of the capillary? Yep. Do you think they can accidentally bump in the wall from that side? Yeah, they can. Are they under pressure? Probably not. So there are going to be fewer hits per square micrometer of a wall. Would you agree with me? So that pressure is called hydrostatic interstitial pressure, and it's maybe 1 millimeter of mercury. Now, would you agree with me that hydrostatic capillary pressure forces the fluid to go out of the capillary through the wall? And it's a powerful pressure. Whereas the hydrostatic pressure of interstitial fluid pushes the fluid to get back into the capillary. Agreed? Right? Okay, fantastic. Now osmotic pressure. That's where really things get a little bit more fuzzy. Okay, so first of all, when we talk about osmotic pressure, we talk about pull on the water based on unequal concentration of water on two sides. So let me see, I brought my teacup, here it is, and I spilled it. Here is a big puddle of my tea on the desk. Can everybody see it? I'm gonna take a dry sponge and I'm gonna put it just on the very edge of that puddle. Just barely touching that puddle. What are you observing is happening with my puddle and with my sponge?
It's being drawn to the.
Did you notice I didn't need to bring and make a mess? You are perfectly able to use your imagination, which is way more efficient actually, because you are thinking, you're participating rather than, I don't know what she's doing, making a mess, right? But that sponge is sucking in the water. Why? Because that sponge is very dry. And the puddle is very wet. What does it tell me? Concentration of water in the sponge is very low. Concentration of water in the puddle is very high. We are moving towards equalizing concentration. Right? Would you agree with me? Okay. So what creates osmotic pressure in cardiovascular system? Okay. There are proteins in the plasma, most notably albumin. These molecules are too large to go through a continuous or even fenestrated capillary. So they stay in, creating less space for water, which makes a lower concentration of water. So what it does is it sucks the water into the capillary, just like my sponge. That is osmotic capillary pressure. That pressure is about 25 millimeters of mercury, give or take. Okay? So far, so good? So osmotic capillary pressure pulls the water back into the capillary because the plasma proteins they create a certain concentration and the water comes in to dilute it. Make sense? Now, do you think there are proteins over here? Of course they are. We already know, like collagen, elastin, all of these are extracellular proteins, right? So, do you think they're gonna pull? Yeah, they're gonna pull the water in their direction, right? And so, it's about 3 millimeters of mercury. So far, so good? Okay, so now we're gonna play a game of adding them all together. And it's like a tug of war. There's gonna be a team of pressures that pull the water in, or fluids with everything else. It's not just water, it's everything else with it, right? Whatever fits through the holes or through the membranes, right? So there's gonna be a team that's gonna try to pull that stuff in, and there's gonna be a team that's gonna try to push it out of the capillary. Whichever way team wins, that's the overall pressure gradient and the direction of flow through the capillary. Does that make sense? Very logical, and that's what I love about cardiovascular system. It's very logical, okay? All right, let's try and practice a little bit. Which of the following is responsible for generation of hydrostatic capillary pressure? Heart? Yup, good job. Good job, that's the heart. You agreed? Yep, okay. Osmotic pressure in the capillary, so capillary osmotic pressure, pulls the fluid into or out of the capillary? Into the capillary. Right, very good. All right, so net filtration pressure is a sum of these pressures with their direction. So there are two ways approach that you can take. You can just memorize the formula if you'd like. You can just memorize the pressures. Hydrostatic pressure in the capillary plus osmotic pressure in the interstitial minus a sum of hydrostatic interstitial and osmotic capillary pressure. If you prefer memorization, by all means. What I have to do is always think my way out of it. Yeah, to me, that's an easier way to handle a problem. Because I forget formulas, I forget details, but I can always rely on my noodles. And you have great noodles too, you can rely on them, okay? So, let's see what we can see on the arterial end of the capillary. We said hydrostatic pressure in the capillary is about 35 millimeters of mercury. And that's a pressure out, would you agree with me?
Mm-hmm.
Hydrostatic pressure of interstitial is about 1 millimeter of mercury, okay?
Mm-hmm.
Osmotic pressures, capillary pulls the fluid in, and it's about 25. Interstitial pulls the fluid out, and it's about 3 millimeters of mercury. So instead of doing a formula, all I'm going to do is I'm going to say, what are my pressures that move the fluid out? Well, this guy and this guy. That's about 38 millimeters of mercury together. Do you see that? What are my pressures that try to return the fluid? Well, it's this guy and this guy. Looks like 26 millimeters of mercury. Okay? So which team is winning? Team in or team out? Team out. So what I'm gonna do is I'm gonna take 38 minus 26. That gives me 12 millimeters of mercury. It is a positive number. It is a filtration. Okay? I'm filtering things out. I'm moving them out. That's on the arterial end. Now let's see what happens on the venular end. Now again, when you are going through these examples at home, please do, but do not bother memorizing specific numbers. These numbers vary all the time. They may be varying between capillaries over here versus capillaries over here. They may be differing in capillaries over here during different states of the body, a different activity of the organ, and so on and so on, during different blood pressure and so on. So it's just an example that helps you understand how things work. So on the venular end, hydrostatic pressure is about, in the capillary is about 15 millimeters of mercury, right? We are further away from the heart pump, okay? Hydrostatic pressure in the interstitium is about millimeter of mercury. Osmotic pressures did not change. So my approach is exactly the same. This is team out. This is team in. Do you see that? Okay. All right, so my team out is 15 and 3, 18 millimeters of mercury. My team out is 25 and 1, 26 millimeters of mercury. Same approach, 18 minus 26. What's my total? Looks like negative 8 millimeters of mercury. So overall direction in, and that is called a reabsorption. That's why the fluids are moving out of the capillary on the arterial end and are reabsorbed on the venular end. How cool is that? How cool is that? Logical. Very logical. Now, why do you give a damn? It's like, well, I'm a nurse. Why do I care about the osmotic pressure and so on? You need to know a word, edema, and that's actually a very commonly used term, but what it means is swelling, okay? And swelling is a symptom of many things. It's not a disease. It's a symptom of many things. Let me show you how multiple things can generate swelling or edema. Okay, I'm gonna start with hypertension. Hypertension is high blood pressure. Which of these factors is gonna be changing when your systemic blood pressure is high all the time?
Hydrostatic pressure.
In the capillary. So now I have way more forces out than forces in on this side. I will end up, if I have more filtration than reabsorption, then what will happen? Swelling, exactly. Second example, liver failure. So liver has to do with swelling. Okay, liver produces all plasma proteins with an exception of gamma proteins, or gamma globulins. That includes albumin. Albumin is made in the liver. So your patient has liver failure, cirrhosis, hepatitis, some severe situation. Liver is not working. Albumin is not produced. Which of these factors is going to change? Osmotic pressure in the capillary. So it's going to actually decrease without it, right? So again, I'm now going to have more forces out than forces in. Would you agree with me? Same outcome. You see that? Swelling, edema.
In liver failure patients, don't you most often see like the swelling in the abdomen?
Mm-hmm. Well, it's actually affecting all of the capillaries everywhere in the body. But why is it happening? Because you have cavity to store them. So it cannot accept the most amount. And that's called ascites. And so what you will see is, I practice medicine in Russia, and alcohol abuse is a huge issue there. We've never seen drugs, but now they're there. But with Iron Curtain, we've never seen drugs. I went through a med school, and I remember third year in pathophysiology exam, my question on the state exam was drug abuse. And I had to wing it because I didn't know about drug abuse. But you know what? My professor didn't know either. So I got a good grade. So why is it? Because we haven't seen them. But alcoholics? So here will be a little dried up, little just shrunken down to nothing man, because they have malabsorption in the stomach, atrophic gastritis. So he's got no body mass. And he's got a belly like he's 9 months pregnant. Huge, horrible. Now, please don't think that anybody with liver failure is an alcoholic, because there are multiple reasons that could lead to that. But in Russia, that was a leading cause. And so what you would do is you would put them in the chair. We didn't have ultrasound available very readily. So you'll do percussion to make sure that there's no gut sitting against the wall. You'll do a little local anesthetic. You make a hole and stick the tube in their belly. And they sit there in that chair with a tube sticking out of their belly in the bucket between their legs. And 3 days later, they're back. And liver transplants were not very successful at that time, but that's really the only outcome for them. So, where you can fix it. So, anyway, sorry, I got a little sidetracked here. So far so good? Now, and yet another reason, blood clots in veins. Deep vein thrombosis. Why would that lead to a swelling? Okay, so what happens with a blood clot in the veins is, so this is my venular end. So I have a clot somewhere down the road over here. So yes, back up in the system. So that would lead to increase of hydrostatic pressure on the venular end. So my reabsorption will drop, right? So far so good? And that, folks, is how edema is created. There's one more reason that I will discuss with you. Well, let me just step ahead just for 1 second. And it's part of the next lecture, but I want us to kind of finish that thought. Okay. So did you notice that in my example, and it was a very realistic example, my filtration on the capillary end was with a pressure gradient of 12 millimeters of mercury, you remember? Mm-hmm. And reabsorption was with -8. If these numbers were true, what do you think would happen? Yeah, these numbers gotta be the same or I'm gonna be in trouble, because I'm filtering more out than I'm reabsorbing. These numbers are actually accurate, but there is one more method of returning the blood into general circulation. And that, folks, is lymphatics. There is yet another system of capillaries. And these are not connected to blood capillaries. They start as blunt-ended and they're very, very low pressure. So they just suck in, there's no resistance from within, right? Because they're empty. So, and that is lymphatic capillaries. They're very leaky, they collect that extra fluid. Make sense? So my true vascular bed looks like something like that. I have a blood capillaries that start with an artery and drain into a venule. And then I have lymphatic capillaries that don't connect, but they drain the same area. Does that make sense? So what happens with those is these form bigger vessels and bigger vessels and bigger vessels and bigger vessels, and eventually they drain. They also go through lymph nodes. Why is that important? We will, in our next unit, we will talk about blood and immunity. And you will learn that if there is like a cut or something, bacteria enter, some of them will actually be collected with lymph and travel, but I don't want to let them into systemic circulation because that's like disseminating it through a whole body, right? So it's kind of like a roadblock where, have you seen, I don't know if they do that anymore, definitely not in California, but in California, if you're driving like on I-5, there'll be like a random stop and check your ID, especially close to Mexico, right? Mm-hmm. So it's the same idea. It's a roadblock where they're checking ID. Oh, you don't have self-ID. You must be an illegal alien. You're a bacterium. We're gonna phagocytize you. We're gonna kill you. Does that make sense? Okay. Your body doesn't take prisoners. There is no like, okay, now you can vote. So that's how that works. Everybody with me, and I'm an immigrant. Yeah. Okay, so that's lymphatic system. We will worry about the lymphatic system later in our discussion of immunity. But what I want you to see is that eventually from there it goes and drains into subclavian vein. So we return that into the general circulation, that fluid with all of the stuff. So if any of these lymphatic from capillary all the way to the drainage into subclavian vein are obstructed or compressed, we will have compromised return of the fluid. And again, we will see swelling. Does that make sense? Mm-hmm. So here you are seeing two arms of a lady who went through mastectomy for cancer. And when we do mastectomy, we also remove regional lymph nodes because we are concerned that the metastatic cells would travel, and that's where they would like to seed first in local lymph nodes. So we remove those, especially for tumors that are likely to metastasize through lymph pathway. Okay? So we remove that, but what happened? We disturbed that return, and now she has lymphedema. And that lymphedema may be for life, and sometimes it gets better. There are different physical therapy exercises, massages, whatever. All of that is mostly praying that goes into that, and moderately helpful, okay? But literally what happens is you remove yet one way of returning the fluid, and of course now you have an edema. Make sense? So that's kind of to finish our conversation on edema. So far so good? So the lymph is returned from there is asymmetry. Remember how we had hemiascus vein? Those were not symmetrical. There was no right and left. They were just weird, right? So the return of the lymph is also asymmetrical. So on the right side, we have a right lymphatic duct that collects lymph above the diaphragm from the right side of the body. Okay. On the left side, we call it a thoracic duct. And thoracic duct collects above the diaphragm from the left side of the body, plus everything below the diaphragm. Which means from the abdomen, it goes into a thoracic duct, which goes on the left side. Make sense? So far, so good? Okay. All right, the venous system for next time. Questions for me? Yes, sir.
So if somebody has lymphedema, like lady in the picture, will the swelling get bad enough to where it needs to be drained? Or
Usually not. Usually not. So basically, that swelling eventually kind of penetrates through the tissues. It kind of increases the pressure in the interstitium and kind of drains around it, but it's uncomfortable. It's uncomfortable for that. It can cause paresthesia where she feels numbness or she feels discomfort, not to mention they're just different size.